Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, really deeply impacted, dry earwax and dead skin to keratin, and they were really struggling to hear. I'm just commencing with this, their right ear first, and I'm just using the Zollner suction probe to perform microsuction, and as you can see, I'm just lifting this dead skin off the ear canal wall. So if you enjoy skin peels, which I know a lot of you do, this is the video for you. So you can see the underlayer of the skin, it's a fresher layer of dead skin, whereas the top portion of the dead skin, it's actually oxidized, so it's become more brown in appearance. And I'm just at the front of the ear canal now, and I'm just slowly but surely peeling away this dead skin. I believe in part this patient's impaction is self-inflicted. They did admit to using a Q-tip, so a cotton bud, and what a Q-tip and cotton bud can do is actually further impact this dead skin. In the majority of people, as the ear canal sheds the outer layer of skin, the epidermis layer, this skin dies and sheds, and it should naturally migrate out of the ear on its own accord. So think about the skin on the ear canal moving sideways like a conveyor belt, and any earwax sitting on the surface of the skin is therefore also transported out of the ear. And this rate of migration of dead skin out of the ear, it ranges between 1.5 and 3 millimeters a month. So this process of the skin migrating actually commences from the middle of the eardrum. The middle of the eardrum, we call that the umbo, and the outer layer of the eardrum is made up of the same skin that lines the ear canal. So as this skin sheds from the eardrum, I always make the analogy and compare it to dropping a pebble or stone in the middle of a pond, and you have that ripple effect. And imagine those ripples being dead skin on the eardrum, migrating sideways radially out off the eardrum onto the ear canal, and then eventually out of the ear. And our ear canals, on average, or an average adult ear canal length is around 2.6 centimeters in length from the entrance to the eardrum. So approximately, it does again vary depending upon the individual length of a person's ear canal and also their individual rate of migration of dead skin, but it can range between 10 months to 18 months for dead skin to naturally by itself migrate out of the ear. Now, of course, for some people, this skin doesn't migrate. There can be clinical reasons for that. For example, it is well documented patients who have undergone radiotherapy around their ears and heads, they lose the ability for the skin to naturally migrate. They also tend to produce dry wax because some of the ceruminous glands and sebaceous glands, they lose their ability, their function. They're damaged in the process of undergoing radiotherapy. So the ear naturally produces less oily secretions, and these oily secretions, if they do, they're a bit drier. The most common cause as to why this dead skin doesn't actually migrate is through, as I mentioned earlier, using cotton buds or Q-tips, or wearing hearing devices, whether it's a hearing aid or a Bluetooth ear pods, and all these other things that you see nowadays people wearing. So all these things kind of inadvertently push the earwax deep in your ear. People who wear ear defenders or sleep or swim plugs. So these are all factors. There can sometimes be anatomical reasons if people have got really narrow, small, twisty ear canals. So as the skin tries to migrate, it can get trapped within a narrowing or around the bend, for example. If there's any abnormal defects in the ear canals, if there's any trenches or divots or little potholes within the ear canal, dead skin can drop into those openings and widenings and potholes and then fail to escape. And patients who have undergone outer ear canal surgery or a mastoidectomy, so when the bone behind the ear canal gets infected and it's drilled out, to then become one with the ear canal. So we call that a mastoid cavity. So patients who have mastoid cavities, for example, or sometimes patients who have undergone other types of ear surgery, they are prone also to developing earwax and dead skin. So as you can see, there's many different causes. So the patient's right ear was successfully treated. We're now removing this dry dead keratin off there from the left side. Upon attending, they didn't actually notice this ear was blocked because their right ear was significantly the worst out of the two, and it was only after I cleared their right ear so they could again hear from that ear that they then began to notice that this left ear wasn't as acute as they as it was when they first attended. So they requested I remove this for them. It's a similar issue. This dead skin has been impacted. You can probably tell by the location, and there is also an indentation within the surface of the skin where the cotton bud has been used. So once more, just peeling it away. And you can use that, you can see that rocking motion I'm using with the suction probe. I'm just going up and down, trying to loosen the skin off the canal wall, and as I'm slowly coming away with the suction probe. I'm just going to go back in. I think I used some olive oil spray as well in this side like I did in their previous year. What the olive oil spray does, and we use medical grade olive oil by the way, it helps to lubricate the canal walls, so to reduce friction, which therefore helps the removal of earwax. The olive oil spray also lubricates the inside of the suction probe, so it prevents blockages from occurring quite often, especially if you've got really soft, gooey, mushy, glutinous earwax. As you're suctioning that, given the consistency, it can sometimes block the inside of the suction probe, so you're therefore forever coming out of the ear and unblocking the suction probe. So olive oil spray can help to reduce blockages, and of course it can help to soften the surface of this wax and skin so I can get a better suction grip. And in the cases of very mushy glutinous type of wax, the olive oil helps to bind that together. Otherwise it's very difficult to suction that particular consistency of earwax. Now, you may have noticed as I'm coming out, and also within the ear canal itself, they have got superficial otitis externa, so they've got dry skin there, dry skin flakes. They've been suffering from this dry skin, so we classify that as otitis externa over the last couple of years, and they do occasionally have to have some antibiotic ear spray prescribed. Otherwise, they just manage it with a combination of using drops on a regular basis. So olive oil drops or spray, because that helps to lubricate and hydrate the skin, preventing it from drying and cracking. And also over-the-counter acetic acid spray for the ear. They find that helps. I suspect the reason why they're getting this wax buildup is because of the dry skin. But the skin wasn't able to naturally migrate outwards because they had been using a cotton bud, because their ear was really itchy. And you may have seen as we're entering, the patient's got a few scabs on the outside part of the ear because it's evident that they've been scratching that part of the ear too. So the eardrum is fully visible. I just want to remove this dry skin now off the canal wall if possible. We do have to be careful because we're now in what I call the danger zone. Think about the ear being subdivided into thirds. So the outer third, so the what we call the lateral third, which is towards the entrance, near the entrance, that's made up of cartilage, and the skin that lines the cartilage is extremely thick. It's 1 millimeter in thickness, and it's made up of 3 layers. You've got the epidermis layer, so the outer layer of skin. You've got the dermis, which is the middle layer of skin, and then you've got this subcutaneous layer, which is the most inner layer of skin, and that's made up of insulating fatty tissue and connective tissue. So the cartilage portion of the ear canal is very well protected and buffered by this thick layer of skin, and of course cartilage is flexible in the mainstay, it's not rigid like bone. Then you enter the inner 2/3 of the ear canal, and we call that the osseous portion of the ear canal, or the bony part. And the bony part of the ear canal is extremely delicate and sensitive. Of course, bone is rigid, as I was just discussing, so it's not flexible or malleable like cartilage. But the skin that lines the ear canal, and the inner 2/3 of the ear canal, the bony part, and also the outermost membrane of the eardrum, that's just made up of epithelial skin cells. So you've only got an epidermis layer. You don't have the dermis, and you don't have the subcutaneous layer. Therefore, the skin that lines the ear canal, the bony part, is extremely thin. It's 0.1 millimeters in thickness, so it's 1/10 of the thickness of the cartilage portion of the ear canal. And subsequently, it therefore means there's less of a buffer, and the bony part of the ear canal is far more sensitive. That's why whenever I'm working really close or deeper in the ear, we're always careful anyway, but particularly so when we're working on the bony part, and I'm just hovering over. If it comes away, brilliant. If not, I'm not overly concerned, but so far so good. And there's some of this dry skin, it's really crystallized. It's quite, we can always describe it as shards of plastic or glass. It is got a rough texture and edge to it. And I'm just going to mop up now. This is quite literally near the entrance of the ear, probably just past the first bend. So our ear canals, I'm going through a lot of ear anatomy today, which is great. Our ear canals are, well, there should be, or the majority of our ear canal, should I say, is an S-bend. So it takes the shape of a snake almost, and we call that a sigmoid shape. And the first bend in the ear canal is about 0.5 centimeter upon entering, and the second bend is a further 0.5 centimeter. So the second bend is where the cartilage portion of the ear canal meets the bony part, so it's called the osseo-cartilaginous portion of the ear. And just getting some dry skin off the back part. So when you enter the ear, so for example, this is of course the patient's left ear, there quite often can be a blind spot on the rear lateral end, so we call that the posterior part of the ear canal, the back portion, but near the entrance, so the lateral aspect. And vice versa in the right ear, when you enter the ear, there's quite often a little blind spot to the left just as you enter. So we're all done there. Well, I hope you enjoyed that video, guys. Do stay tuned, I've got loads more videos to upload in due course. Thank you, bye.